Vitamin B12 gets absorbed from which part of the gastrointestinal system? There is very easy mnemonic to remember: site of absorption and micronutrients. Dude is just feeling ill, bro. Iron is getting absorbed from duodenum. Folic acid is getting absorbed from jejunum. And vitamin B12 getting absorbed from terminal ileum. Welcome back to my channel. In today's video, we are going to learn many one-liner, many MCQs and many biochemistry reaction about vitamin B12 in very easy language with lots of diagram and flowchart. Do not skip anything, watch till the end. Let's get started. Hi, my name is Dr. Triyavirani Malde, pediatrician and consultant neonatologist. I'll be your guide for pediatric subject. If you are new to my channel, please do subscribe and give like to this video because lot is going to happen for pediatrics on this channel. So question number 1 is vitamin B12 gets absorbed from which part of the GIT? Your options are stomach, duodenum, ileum or jejunum. Correct answer is option C, ileum. So what is vitamin B12? It is cobalamin. It is water soluble vitamin. It is red in color. It is very heat stable. It is synthesized by only microorganism, and food of any animal origins are the only sources such as dairy product, poultry, liver, egg and milk. So what is very easy mnemonic to remember? The site of absorption of few micronutrient. Dude is just feeling ill, bro. So iron is getting absorbed from duodenum. Just feeling. Folate is getting absorbed from jejunum and vitamin B12 is getting absorbed from ileum. Question number 2. Which is the synthetic form of vitamin B12? Your options are methylcobalamine, adenosylcobalamine, hydroxycobalamine or it is a cyanocobalamin. The correct answer is option D, cyanocobalamin. We are going to know all the facts about vitamin B12 natural and synthetic form in next slide. So we have to remember that vitamin B12 occur in two form, natural form as well as synthetic form. In natural form, we have two form, active form and inactive form. In active form, we have a methylcobalamine and adenosylcobalamine. These two play very important role as a cofactor for many coenzyme for very important reactions. While synthetic form, which comes as inactive form, is known as a cyanocobalamin. As we discussed that cobalamin in a two form plays very important role for the few of the biochemical reaction in our body. Cofactor role of adenosyl B12 is a coenzyme for methylmalonic CoA mutase. Just remember that methylmalonic CoA mutase is getting converted into succinyl CoA, which is important for citric acid cycle. Whenever there is a deficiency of cobalamin, adenosyl B12 cannot work and there will be an increase in the amount of methylmalonic acid. The second important role played by methylcobalamine is a cofactor role of methyl B12 for coenzyme of methyl transferase, which is important in conversion of homocysteine to methionine. At the same time, 5-methyl tetrahydrofolate getting converted to tetrahydrofolate, which is very important for the DNA synthesis. So that this is second role. Whenever there is a deficiency of cobalamin and methyl B12 is not there for this reaction, what is going to happen? There will be increase in the homocysteine as well as the folate get trapped as a 5-methyl tetrahydrofolate, which is not active form of the folic acid. So it plays important role for purine metabolism, maturation of RBC as well as the fatty acid synthesis of the myelin. Question number 3 is name of the receptor present in the ileum for the absorption of vitamin B12. Is it intrinsic factor, is it tubulin, is it heptocorin or is it R binder? The correct answer is option B, that is tubulin. So we are going to understand vitamin B12 absorption, the whole process in a very simplified manner. Please pay attention over here that vitamin B12 is a very fragile vitamin. It cannot go alone. It requires some or other protein component or some binding things which can facilitate its absorption and its movement through the GIT as well as the bloodstream. Vitamin B12, it is bound in some protein in the diet. So it is called vitamin B12 protein complex. So just remember that initially vitamin B12 and protein complex gets moved to the stomach. Because of the stimulation, the salivary gland also produce these all three are synonym of each other, heptocorin, R binder or a cobalamin, which gets moved along with the diet in the stomach separately from the protein vitamin B12 complex. The next step is this protein vitamin B12 complex act by pepsine of the stomach And after that, the vitamin B12 gets separated and gets bind to the heptocorrin, which is already secreted by salivary gland in a previous state. So now we have a vitamin B12 heptocorrin complex. Remember, here the parietal cells of the stomach will produce intrinsic factor of the Kessel, but it's not going to bind at this stage. Now B12 and heptocorrin are getting moved to the duodenum. Intrinsic factor is also getting moved to the duodenum. In the next stage, pancreatic enzyme as well as the bile acids dissociate this complex. So again vitamin B12 get released from the heptocorrin and it will get bind to the intrinsic factor which is already secreted by the stomach. Now this complex will move to the terminal ileum where it get absorbed by the receptor called cubulin. So correct answer of the previous question, that which receptor is present in the ileum, is cubulin. So this cubulin get absorbed through the intestinal lumen. It will go to the bloodstream. Again you remember, vitamin B12 cannot go alone. It is very fragile form. So in the bloodstream we have Cobalamin 2 which gets again bound to the vitamin B12 and get moved into the bloodstream. So correct answer is cubulin. Question number 4. Liver in our body stores vitamin A, vitamin K, vitamin B12, or is it all of the above? So correct answer is all of the above. Just remember that liver stores all fat soluble vitamins, that is A, D, E, K as well as vitamin B12. The next question is, which of these statements about B12 is false? A. Deficiency of this vitamin lead to neuronal migrational disorder. B. Pure vegan will have its deficiency. Intrinsic factor is needed for its absorption. Or damage to the gastric mucosa may lead to its deficiency. See, neuronal migrational disorders are lissencephaly, which is seen in a newborn, which is because of abnormal migrational of the neurons. It is not linked to the vitamin B12. So this statement is incorrect. We all already learned that pure vegan may have deficiency of vitamin B12. We all just now understood that intrinsic factor is important for the absorption of vitamin B12. Damage to the gastric mucosa may lead to its deficiency because damage to gastric mucosa will not produce intrinsic factor. So again it can cause deficiency of vitamin B12. So correct answer is option A. Deficiency of this vitamin lead to neuronal migrational disorder because it is not related to vitamin B12 deficiency. So what are the things can lead to the vitamin B12 deficiency? As first of all, that pure vegan will end up with its deficiency. So dietary deficiency. Salivary gland, few of the syndrome which can affect the salivary gland, one of it is Sjogren syndrome, can lead to decreased secretion of the heptocorrin, R-bindrin or a cobalophenil, in which there could be no absorption of vitamin B12 from the GIT. If parietal cell of the stomach will not produce intrinsic factor of Kess, may lead to pernicious anemia. If there is a exocrine pancreatic deficiency, because bile acids and pancreas are important for the dissolution of the complex of vitamin B12 along with the heptocorrin. So if there is a deficiency of pancreatic enzyme, this may lead to deficiency of vitamin B12, and as the major site or the only site of the vitamin B12 absorption is terminal ileum, so any causes which is related to ileum, ileal reaction, Crohn's disease, celiac sprue, this all can lead to deficiency of vitamin B12. So these are the causes in which we can have a vitamin B12 deficiency. So question number 6. Assertion is vitamin B12 deficiency cause subacute combined spinal cord degeneration. Reason is vitamin B12 causes nerve cell apoptosis. This is the statement and this is the reason for this statement. We need to see the options now. Both A and R is correct. A is the correct explanation. Both A and R is correct. R is not the correct explanation. A is correct. R is false. R is correct, A is false. First of all, we all know that assertion is correct. A is causing, the vitamin B12 can cause subacute combined degeneration of the spinal cord. That is correct. But we should know that vitamin B12 can cause nerve cell apoptosis. No, this statement is not correct. Option A and B is out because both of them are saying A and R is correct. We know that R is not correct. So option A is out, option B is out. Now let's see option C. A is correct, R is false. Yes, this is correct. R is correct, A is false. This is not also correct. So correct option is option C. A is correct and R is false. So vitamin B12 deficiency will not cause nerve cell apoptosis. It causes demyelination, decreased methylation of myelin sheath. So it will lead to demyelination, not nerve cell apoptosis. So that reason was incorrect. So what all things will be caused by deficiency of vitamin B12? This is normal red cell with normal neutrophil. In case of the vitamin B12 deficiency, we'll have a macrocytic anemia, as well as we'll have a hypersegmented neutrophil. In a pediatric patient, particularly, we can have a regression of the milestone. There could be an infantile tremor syndrome. It can cause a subacute combined degeneration of the spinal cord, as well as we all know that it can cause increased level of MMA, as well as increased level of homocysteine. This is again an important question, that how do we remember what all things are involved in SACD? We have to remember for SACD short form S, C and D. S stands for spinocerebellar tract, so hyperreflexia and spasticity will be there. C stands for involvement of corticospinal tract, so there will be again hyperreflexia and spasticity. While D stands for dorsal column. D stands for dorsal column, posterior column and dorsal root. So it can cause impairment of proprioception as well as vibration in hands and feet. It can cause sensory gait, ataxia, as well as it can cause distal muscle weakness. What this image is showing, which vitamin deficiency associated with the finding. First of all, see the macrocyte and then see the hypersegmented neutrophil. It is not a WBC, it is neutrophil. It is hypersegmented neutrophil. It is seen in megaloblastic anemia, which is caused by the deficiency of vitamin B12. What this image is showing, it is T2 weighted sagittal axial image of cervical spine, in which there is a hyperintensity in the spinal cord, as well as we can see arrowhead sign or a inverted V sign in a dorsal column. You can make out here this shows subacute combined degeneration of the spinal cord, which is seen in vitamin B12 deficiency. Folate trap is due to deficiency of vitamin B12, vitamin B6, methylated form of folic acid, or it is both B and C. Methylated form of folic acid is not the option because we have already learned that tetrahydrofolate get trapped in that form without a presence of vitamin B12. So correct answer is vitamin B12 cause folate trap, and this is because of this reaction, that methyl tetrahydrofolate is getting converted to THF. At the same time, cobalamin get converted to methylcobalamine and homocysteine get converted to methionine. So if there is no cobalamin, this methyl tetrahydrofolate will get trapped in the same form and it is not available. So B12 deficiency lead to functional deficiency of folic acid. Recent studies have suggested that increased serum level of homocysteine may predispose to thrombosis. We all know that homocystinemia can cause thrombosis, and that decreasing homocysteine level may benefit patient from decreased risk of coronary and cerebral artery thrombosis. Correct? If we reduce the homocysteine, there will be a reduced risk. Folic acid and vitamin B12 can reduce serum homocysteine level according to following mechanism. It's the same reaction. We need to pay attention that what will be the end result of this reaction. Methyl tetrahydrofolate getting converted to tetrahydrofolate, cobalamin getting converted to methylcobalamine, and homocysteine is getting converted to. This all thing is there to make you more confused. Otherwise, the simple answer is, with the presence of cobalamin, methylcobalamine, and this reaction, homocysteine will get converted to, we all know the answer, methionine. But we need to remember that at the same time, when we are going to learn vitamin B6, that is pyridoxine, homocysteine get converted to cysteine. So if there is B6 in the option and it is related to pyridoxine deficiency, then the answer could be cysteine. But here, when there is a homocysteine, methionine and vitamin B12, these only two things are associated for homocysteine to methionine. So correct answer is methionine. Question number 11. Which vitamin deficiency will present same as vitamin B12 deficiency? Your options are vitamin A, vitamin D, vitamin E or vitamin K. We all know vitamin A is related to eye, so it can cause xerophthalmia and the symptoms related to eye, which is not related to B12. Vitamin D deficiency in pediatric can cause rickets, so this is also out. Vitamin A can cause hemolytic anemia as well as spinocerebellar ataxia. So yes, this is related to vitamin B12, while vitamin K deficiency will lead to hemorrhagic disease of newborn. So correct option is option C, vitamin E. How he is going to cause such kind of deficiency? Vitamin A active form is known as alpha tocopherol, and its deficiency will lead to hemolytic anemia as well as spinocerebellar ataxia and axonal degeneration. And vitamin B12 we all know can lead to anemia as well as spinocerebellar ataxia. Question number 12. To differentiate vitamin B12 deficiency from folic acid deficiency, which of the following has to be considered? Your options are: A, vitamin B12 deficiency will lead to increased level of homocysteine while MMA is normal. Option B, B12 deficiency both homocysteine and MMA increased. In vitamin B12 and folic acid only homocysteine is increased, MMA is normal. Or it is D, folic acid deficiency, homocysteine and MMA both is elevated. We have already learned about it, that correct option is vitamin B12, homocysteine as well as MMA is increased. We'll have a quick revision of it. We all know that vitamin B12 in a form of adenosyl B12 as well as methyl B12 is responsible for two important reactions, that is methylmalonyl CoA to succinyl CoA as well as homocysteine to methionine. In absence of vitamin B12, methylmalonic acid will also increase as well as homocysteine will also increase. So correct answer is option B. What are the investigation we are going to consider in a vitamin B12 deficiency? Serum B12 assay, serum homocysteine as well as MML level, peripheral smear to look for megaloblast, teardrop RBC as well as hypersegmented neutrophils. Question number 13. A person who is on mixed diet presented with weakness, tiredness, macrocytic anemia and subacute combined degeneration of the spinal cord. He was given radio-labeled B12 orally and vitamin B12 injection intramuscularly. 24 hours urinary excretion of the radio-labeled B12 was less than 10% of the orally administered dose. After administration of oral IF, 24 hours urinary labeled B12 was more than 10% of orally administered dose. Which of the following is the probable cause? That whatever is described here is causing a skilling test, right? So what is skilling test? It's to identify presence of vitamin malabsorption and to identify the cause of vitamin B12 malabsorption. So what we are going to do in this skilling test? Step 1. First of all, B12 and folic acid deficiency has to be treated completely. In step 2, we are going to administer radio-labeled vitamin B12. So in a step 3, we are going to give injection of vitamin B12 to saturate all the receptors which are present in the liver. So after these 3 steps, we are going to do, so once we have given oral radioactive vitamin B12 as well as we have given intramuscular vitamin B12, then we are going to measure radioactive excretion of vitamin B12 in the urine. If it is less than 10%, it just prove vitamin B12 malabsorption. It will not tell us at which site the absorption is having issue. So if it is less than 10%, the vitamin B12 malabsorption is proven. If it is more than 10%, it means there is no vitamin B12 malabsorption. Now the next step is, if there is reduced urinary excretion of vitamin B12, first step we are going to give intrinsic factor, and after giving intrinsic factor, if there is improvement, then it is intrinsic factor deficiency. It can happen in type A gastritis also. But if it is still less than 10%, even after giving the intrinsic factor, we are going to give 3 weeks antibiotic course to see whether it is celiac sprue is not. After giving 3 weeks of antibiotic, again repeating the test, if absorption is improved to more than 10% and there is more than 10% excretion of the urinary B12, then it is celiac sprue. But even after treatment with 3 weeks antibiotic, the excretion is still remains less than 10%, then we are going to supplement with pancreatic enzyme. And after giving pancreatic enzyme, if the excretion of the urinary B12 improves to more than 10%, then it is pancreatic insufficiency. Let's come back to our question. A person who is on the mixed diet, suppose this is the first and foremost thing, he is on the mixed diet. The patient who is on the mixed diet will not end up with the vitamin B12 deficiency. So option A, dietary deficiency of vitamin B12 is out. Is it a methyl folate trap? In a folate trap or a folic acid deficiency, there will be no CNS symptoms. So this is also out. Here no mention of pancreatic enzyme administration is done. Only at first step, after administering intrinsic factor orally, there is improved excretion of vitamin B12. So it is intrinsic factor deficiency which is seen in type A gastritis. Question number 40. Neurological worsening with anemia is a feature of, your options are vitamin B12 deficiency, combined vitamin B12 and folic acid deficiency. Is it a feature of folic acid deficiency, or it could be a thiamine deficiency? Neurological worsening with anemia is a pure feature of vitamin B12 deficiency, because vitamin B12 deficiency will lead to folic acid deficiency. Folic acid alone will not cause neurological worsening. Folic acid deficiency will only lead to anemia. So correct answer is option A, vitamin B12 deficiency. That's all about today's lecture. I hope you all understood and learnt well. Your suggestions are always welcome for the improvement of my topics. Please let me know what else you would like to learn from me. Till that time, take care of yourself, study hard as well as study smart.